Good afternoon, good evening, and good night, friends and colleagues from all across the world. We are back for the 34th day of the marathon, and today we are back in the territory of India with a special guest, Dr. Preetinder Singh, which I will introduce very shortly. Thank you for joining us, Dr. Singh.
My pleasure, Dr. Kanosha.
Thank you. Well, Dr. Singh, you have been quite instrumental to this peer-to-peer international project, bringing our colleagues together for a common source to gain knowledge that is complementary and available at all times. You've been able to leverage technology and social media to bring a lot of information and knowledge to our colleagues without the hassles of membership and so forth. What are your thoughts about how the process has gone and the latest numbers you have seen at the social media level?
The latest numbers, Keanu, are amazing. The target we are supposed to achieve in our due dates, we are going to catch them soon. We've already reached, I think, 75,000, if I'm not wrong. 750,000.
860 as of this morning.
Yeah, so we are closer to our mark. We'll be closer to 10 billion very soon, and it's great to share the way you told the audience just now about the stuff that I'm sharing and all. I have to share. It's lovely to share because we are reaching very good heights, very good lectures, and a great collection of speakers. You're doing a great job.
Yes, doctor, and 150 dentists, more than 150 dentists are currently donating the time operating this platform, this peer-to-peer fashion.
I agree.
And the one thing that brings us all together, it's a team. That's right. It's a dream team, we call it. But one thing that brings us all together.
Yeah, we call it the dream team, yes.
The one thing that does bring us together that we love is education. So I really appreciate your contribution and the contribution of our board, as well as the social media peers and the lecturers that are contributing their time. With that said, doctor, I'd like to kind of give the audience an introduction of who you are and what you have accomplished. Your credentials are outstanding. They stand on its own. But let's get into the professional CV here, bio. Dr. Preetinder Singh, MDS, is working as a senior professor in the Department of Periodontology and AMP, oral implantology in STD Hospital and AMP, Dental College, India, and as a senior consultant in various dental offices around the country. He's the editor-in-chief of the Journal of Periodontal Medicine, the only one that there is, clinical practice, and associate editor of various other famous journals. He was awarded the Best Graduate Award and the gold medal by Kurukshetra University, Haryana, India, during his BDS, based on his outstanding academic record. He has a keen interest in academics, research, and clinical practice. He has around 55 research publications in various national and international journals of repute. Dr. Singh is an invited senior reviewer for 5 leading international journals, indexed by PubMed. He also has 3 textbooks published internationally attached to his career till date. Dr. Singh has a great interest in periodontal implant research field and is an individual speaker for corporate lectures on his expertise in dentistry at a national level and an international level. He also holds a lot of places of doing the first study in India on the use of recombinant PDGF in treatment of gingival recession defects. He is presently working on microsurgery, advanced implantology, PRF, LANAP, and so on. Under his guidance and work, his department was awarded as a Center of Excellence in Dental Implants in his state. Wow. Doctor, you have been busy. It's an honor to have you with us.
Same here. Pleasure to speak on this platform.
And we're certain that our friends here will really appreciate the information you bring to us today. With that said,
hopefully, I do that.
With that said, doctor, we're going to go ahead and get started. We're going to put you in the queue here, and you have the floor, doctor.
Right. Thank you, Dr. Kenner, for a brief introduction, and I'm very much happy to be on this platform to speak on a topic which is one of my favorites, and it's going very nice all over the world.
Dr. Singh, if you don't have the presentation
Yeah,
up, the presentation disappeared.
is it there now?
If you want to click it again and share it, please.
Sure, I will. 1 second.
Yeah, it was up a second ago, and for some odd reason.
Not a problem. I'm just doing it again.
There it is.
Am I there?
Give it 1 second. I should show on the stream. Yes, here we go. Let me get it up in the screen. 1 second, please. And you have the floor.
Thank you very much. So, in association with Global Summit, the Global Interdisciplinary Summit, myself, Dr. Preetinder Singh, is here to speak on the largest global dental summit, which has about 100 speakers of repute, and I'm glad to be a part of it. The topic on which I'm going to speak is today's Operation Blood, a Panacea for Regenerative Dentistry. Regenerative dentistry is the key need of the hour. So before I start with my presentation, would like to say about COVID-19, whatever pandemic is going on right now. Please be safe and healthy. Be safe from coronavirus infection. Be smart and inform yourself about it. Be kind and please support one another. Yeah, so many of you must have seen or read Marvel Comics. We have Archangel. He can use his own blood to heal others. That's what he portrays in his comics. The power or ability to have blood with healing properties. So the power to have blood with healing properties is a combination of healing and blood generation, also called miracle blood or regenerating blood. So basically what I'm trying to say is that blood has a lot of properties and capabilities of healing one's own body and many more to it. We're going to talk throughout the presentation. Divine Healing to the Blood of Jesus by Ernest Anglais. Some nice words. How wonderful to know that God has provided salvation through the blood of Jesus. When God sees you using the blood, you have deliverance. When he sees you using the blood of your healing, the healing is yours. God has provided the blood for more than salvation of your soul. God wants you to use it for your healing as well. The blood applied to your soul will take you to heaven, but why not accept the full atonement and receive the healing you need for your body? Through the blood, you can have deliverance. Accept the fact that the blood can cleanse you from sickness as well as in sin. Everyone can qualify and can meet the conditions of the word sets forth. So basically, there are 4 basic essential elements to the process of wound healing. Number 1, immune and matrix cells and their communication, changes in the vasculature with angiogenesis. Number 3, development of framework and scaffold for cells. And number 4, establishment of a biological seal and space maintenance. So these are the 4 elements we need to require in any wound healing in human body. Coming to the platelets, a very important role derived from the blood. So we are going to talk about platelets and their various derivatives in our presentation today. Why are platelets so special? What's so special about them? Platelet contains granules that store large number of growth factors. We are hearing many things about growth factors. They are in alpha granules. They release on activation when platelets aggregate and adhere to the site of injury or inflammation. They form an intracellular storage pool of proteins vital to wound healing, including PDGF, that is platelet-derived growth factor, TGF, transforming growth factor, and insulin growth-like growth factor, IGF-1. So they all result in the expression of a gene sequence that directs cellular proliferation, collagen synthesis, osteoid production, and so on. It is the activation of platelets and release of the various growth factors that make them special and is the key to enhance tissue repair and healing in our body. So blood clot, if we compare the concentration of platelets in blood clot versus the platelet concentrates, we have only 5% blood platelets in a blood clot. And if we make a platelet concentrate, we have 85 to 95% of platelets in platelet concentrates. So you can imagine what kind of concentration of platelets and their functions we are going to use in healing. Coming to platelet concentrates, various generation of platelet concentrates are there now. Okay, platelet concentrates are not stem cells. They are not mesenchymal stem cells. They are not lipocytes. They are not bone marrow. So to derive various forms of platelet derivatives, we take autologous blood derived from the patient. You can see the first step, centrifuge at various speeds, which we'll be discussing. We have various concentrates such as PRP, various forms of PRP and PRF. They can be used alone or in combination with bone grafts. Then we have activation of PDGF, PDAF, basic fibroblast growth factor, tissue growth factor. Then we have platelet-derived growth, epidermal growth factor, platelet factor 4, insulin-like growth factor 1. All these lead to stimulation of collagen production, improved neovascularization, enhanced bone formation and maturation. And finally, what we achieve is enhanced qualitative and quantitative wound healing and regeneration. Okay, the growth factors we just mentioned in the previous slide, how do they function? Chemotaxis, cell proliferation, or inhibition of various functions, repair of epidermis and inhibit keratinocyte proliferation, mitogenic functions, angiogenesis, proliferation of fibroblasts, keratinocytes, increased capillary permeability, reepithelialization, pro-inflammatory functions. So basically, we are aiming at angiogenesis, fibroblasts, increased cellular proliferations. So all these growth factors alone or in combination, they perform a plethora of activities or a panacea in the dentistry. Coming to the generations, we're talking about first generation of platelets, second generation, and third. First, we have PRP, that is platelet-rich plasma. One is PPRP, that is without the leukocytes. And then is LPRP, that is with the leukocytes. Then coming to the second generation, we talk about platelet-rich fibrin introduced by Chokran. Then we have PRF, LPRF, IPRF, APRF, TPRF. We are going to discuss all of them. And then we have a third generation platelet concentrate, titanium prepared platelet-rich fibrin, that is TPRF. Coming to platelet-rich plasma first, the autologous platelet concentrates, PRP and PRF, are used in various medical fields, particularly in oral and maxillofacial surgery. These concentrates, as we just discussed, they have plenty of growth factors, PDGF, TGF, EGF. They aim in wound healing, particularly in bone regeneration. Platelet concentrates are easy to apply in clinical practice, and they offer a various range of potential benefits, including rapid wound healing, bone regeneration, and can therefore be considered to be new therapeutic adjuvants. Current clinical uses of platelet concentrates, everything and anything. That's what is going on with the use of platelets. Internet marketing for a host of ailments, but we should know what we are using it for. It's the snake oil of today. Cures rheumatism, grows hair, gets rid of wrinkles, etc., etc. And yes, it is true. It is the snake oil of today. Coming to the role in dentistry, in sinus lift procedures, implantology, ridge augmentations, socket preservation, alveolar cleft palate repair, oral nasal fistula repair, intrabony defects, jaw reconstruction surgeries, soft tissue procedures like gingival grafts, subepithelial connective tissue grafts, increased soft tissue healing, endoperio lesions, filling of cystic cavities, a lot many more we are going to discuss. Now, when we talk of regenerative dentistry, it entails the replacement of tissue lost to disease or injury with physiologically equivalent engineered tissues. So basically, with the use of these platelet derivatives, we are going to replace the lost tissue to the best. PRP, also termed autologous platelet gel, PRGF, that is plasma-rich growth factors or platelet concentrate, is essentially an increased concentration of autologous platelets suspended in a small amount of plasma after centrifugation. Immediately prior to application, a platelet activator or agonist, that is topical bovine thrombin and 10% calcium chloride, is added to activate the clotting cascade, producing a platelet gel, which is known as platelet-rich plasma. The concept of PRP started in the field of hematology earlier in the 1970s, when it was used for the treatment of thrombocytopenia. 10 years later, PRP started to be used in maxillofacial surgery, and till date, we have made many formulations and discoveries and a lot more with success in the field of regenerative dentistry. Platelets were thought to have only hemostatic activity in recent years, but with scientific research and technology, a new perspective on platelets and their functions suggests they contain an abundance of growth factors which do angiogenesis, stem cell migration, and cell proliferation. PRP is a natural source of signaling molecules, and upon activation of platelets, the pregranules are degranulated and release the various growth factors. Like, we're talking of all of them, don't want to repeat them again. So all these growth factors combined play a role in wound healing. So how do we derive this PRP? 8 ml autologous whole blood from the patient, 2,400 RPM for 10 minutes. We get erythrocytes and plasma plus buffy coat. Then 3,600 RPM for 15 minutes. We get platelet poor plasma on one side, and then we get platelet-rich plasma. And if we add thrombin and calcium chloride, what we get is PRP gel, and then it can be used in combination with bone graft or alone in the treatment of various defects, dentistry defects. Coming to the classification, a proposed classification by Johan Ehrenfest, he gave, there are 4 types of this formulation. One is pure PRP or leukocyte poor PRP. That is, the preparation obtained is without leukocyte and shows a low density fibrin network. Then is leukocyte-rich PRP. The preparations contain leukocytes and show a low density fibrin network after activation. Then is pure PRF or leukocyte-poor PRF. Preparations are without leukocytes but with a very high density fibrin network. And then is leukocyte-rich fibrin. The products are preparations with leukocytes and a very high density fibrin network. So this was the classification. There are certain limitations of PRP. Lack of uniformity in PRP preparation protocol, as different platelet concentrations have different storage time. Release of growth factors is for a very short period of time. So we have to be very quick when we are using PRP in our daily routine. Concern is the use of bovine thrombin. You know, an external agent has to be added in activating the PRP, and it might cause immunogenic reactions. This is quite a limitation of PRP, might induce some immunogenic reaction, and the patient might not behave as you want it to. So coming to a few studies done in my department, this is effect of platelet-rich plasma on regeneration of intrabony periodontal defects treated with hydroxyapatite and collagen matrix as a bone graft using single flap approach as minimally invasive surgical technique. It was a split mouth clinicoradiographic study. I'll show you the figures so that you can understand it better. Give me a second. Give me a second. There's some updates going on a laptop, which is disturbing.
It happens.
Yeah, I don't know. It's not going from the screen.
Do you want to go back into the screen and we can put it back in? I mean, get out of the presentation mode and then.
Is it fine now?
Okay. I mean, we see
Do I
the,
go
yes,
ahead?
there you go.
Yeah, so
Please.
the study I was talking about using platelet-rich plasma in Intrabony bone defects. You can see in the figure the probing depth. We use the stent to standardize this. In the radiograph, you can see the intrabony defect next to the tooth, and we do a minimal invasive approach. I'm a very strong believer of a minimal approach, periodontal surgeries, very less trauma. So we do a minimal invasive flap. After raising the flap, we have debrided the root and smoothened the bone. And we can see the defect very clear. Here you can see we have mixed the platelet-rich plasma with a xenograft, and we are going to place this mixture inside we pushed it into the intrabony defect and we sutured it back. So this is, we did use PRF or bone graft with minimal invasive approach. This picture is after 6 months. You can see the soft tissue contour and reduction in the probing depths. This is what we gained at 3 months. This is what we have gained at 6 months. Almost 80 to 90% resolution of inflammation, a great bone fill, and a very nice reduction in the probing depths we have achieved using PRP with the bone graft. So the intergroup comparison we did with the use of PRP versus non-use of PRP, probing depths at baselines were same. At 3 months, we get better results in PRP, and 6 months more better. Same is the concern when we do the relative attachment levels. We have better attachment levels when we are using PRP. This orange one is the group where you use the PRP. Then intergroup comparison of bone levels. As I showed you in the X-ray as well, we got awesome results in comparison to PRP versus non-PRP group. This is the bone fill we have gained. You can see the graph. We have gained a nice amount of bone, and the patient is, has got rid of the inflammation and has a good anatomy of his gingiva and periodontium. Coming to the next category, a very important and very much used nowadays, platelet-rich fibrin. It represents a new revolutionary step in the platelet gel therapeutic concept. This technique does not require any gellifying agent, as we were using some in PRP, but not more than centrifugation of the natural blood without any additives. Chokran et al., is personally known to me, has written an editorial for my journal. I met him in person as well at a conference in Bangkok. He is a great person. He's developed the PRF in 2001 at France, and the production protocol of PRF attempts to accumulate platelets and release cytokines in a fibrin clot. The protocol for PRF is very simple and simulates that of PRP. Again, we are going to take the patient's blood, around 5 ml or 6 ml, 10 ml, and we put it into the centrifuge for 2700 RPM for 12 minutes or 3000 RPM for 10 minutes, after which it settles into the following 3 layers. As you can see, we have the acellular plasma on the top, we have the fibrin clot, and we have the red corpuscle base. So this is the fibrin clot, or this is the fibrin clot, and here we have a beautiful layer of platelet-rich plasma out to be used in the defects wherever required. Standard platelet-rich fibrin, that is SPRF, and advanced platelet-rich fibrin, that is APRF, they both have different RPMs. We're going to talk about it. Decreasing the RPM while increasing the centrifugation time in the APRF group gave an enhanced presence of neutrophilic granulocytes in the distal part of the clot. So if we get that, we have more osteogenic stimulation. And this is what we want. We need more osteocytes to be stimulated. We need more bone fill. Coming to various types of PRF, we have LPRF. It's a dense clot of fibrin with a minimal interfibrous space. Cells are observed along the whole clot, even if they diminish in the distal PRF clot portions. Then we have the advanced PRF, that is APRF, that is on the RPM of 1300 for 8 minutes. And also we have APRF liquid, which is on 1300 RPM for 5 minutes in a centrifuge. APRF has increased interfibrous space and a higher count of cells inside the fibrin-rich clot. Furthermore, cells are more uniformly distributed inside the clot compared to LPRF, and some cells might also be found in the distal part of the clot. So this is how we are getting more cells in advanced PRF, more growth factors. Coming to the next derivative, IPRF, that's injectable PRF, used in hair therapy, in skin rejuvenation. Many of the divas in dentistry are using IPRF, which are also part of a group. I'm very glad to share this slides with them. It's a development of a PRF injectable solution named IPRF, centrifuged at 700 RPM for 3 minutes, and its derivatives IPRF-M and IPRF+. IPRF-M is at 700 RPM for 4 minutes and IPRF plus 700 RPM for 5 minutes. They are pursued with the aim to deliver a platelet concentrate to physician, which proved easy to use in a liquid formulation. So if it is a liquid, we can inject. Otherwise, it is difficult. If it's not a liquid, we cannot inject a gel. So being a liquid, it can be put in a syringe and injected at the site in the skin for hair therapy, etc. Taking advantage of a slower and shorter centrifugation velocity, it is possible to observe an increased count of regenerative cells with an increased concentration of growth factors compared to the other formulations obtained at higher centrifugation velocity. So now you can see that velocity of the centrifugation also plays a role. The slower the centrifugation velocity, the more regenerative cells we are getting. Coming to the third generation platelet concentrate, that's TPRF, titanium prepared platelet-rich fibrin. Now TPRF is prepared in grade 4 titanium tubes. Rest are all prepared in the glass tubes. Why titanium and why glass? Blood samples are drawn from the antecubital vein and collected in titanium tubes and centrifuged at 2800 RPM for 12 minutes. TPRF method is based on the hypothesis that titanium may be more effective than glass tubes to activate platelets. Why? Because of the presence of some silica activators in glass tubes. And there is nothing of that sort when we talk of titanium tubes. So this is how TPRF is different from Chokran's LPRF method. Properties of titanium prepared PRF: better hemocompatibility of titanium than glass. It is more polymerized, so more better results, and it's longer life of TPRF in tissues. It can act for a longer time. So TPRF is coming to be latest. The only drawback now coming is the procurement of titanium test tubes, but with passage of time, we'll be able to get them all over the world shortly. So these are the concentrations. We just talked about it in a tabulated form. We just talked about them. So this is just a tabulated form of that. Now, does PRF have any advantage over PRP? Yes, there are some advantages of PRF over PRP. No biochemical handling of blood. No, that is no adding of additives of thrombin or calcium chloride. Simplified and cost-effective process. Use of bovine thrombin and anticoagulants not required, no immunogenic reaction. Favorable healing due to slow polymerization. More efficient cell migration and proliferation. PRF has supportive effect on immune system. Since we are using just the patient blood with no additives at all, the immune system will prove very nice to the actions. Coming to various applications of PRF in dentistry, if we talk of perio, we have root coverage procedures. We have good bone fills and attachment. Oral surgery in extraction sockets, pre-prosthetic surgery, periapical surgery, implants to enhance osseointegration, endodontics for regeneration of pulp, damaged roots, cervical or apical dentin, and also pediatric dentistry for pulp capping procedures. So you can see how PRF is getting into dentistry on a daily basis. I'm using PRP and PRF and many more things almost daily in my practice because of the awesome results. Coming to my case, I am showing you a case of PRF. We did an implant placement on an immediate extraction site. You can see the jumping distance. In the first figure, we can see the distance. We have filled this jumping distance with PRF membrane. In the second figure, you can see we have filled this space. This is the picture we see after 4 months, and we see a beautiful architecture of the gingiva. If you compare the x-rays, this is the x-ray at the time of implant placement, and this is the x-ray we achieved at 4 months. You can see the amount of bone fill we have achieved using just PRF in case of an immediate implant placement. Coming to case 2, it is a simple case of extraction followed by an application of PRF inside the extraction socket to promote better healing. Case 3, sinus lift. In case of implant placement, we did a open sinus lift covering the lateral bony window of the sinus with the PRF and addition of bone graft, and got great results. So these are various applications I'm showing, which the cases we are doing daily in my department as well as my clinic. Coming to case 4, we see a very narrow ridge in this case, and we want to place an implant. In the second picture, you can see we have induced in the second picture we have starting the ridge split technique. We have given a cut on the bone, and we have done the vertical splits, and we are doing a ridge split. Now, to fill this ridge split space, I thought, why not use PRF? So here we had made the PRF in a department, PRF in our hands. This is the PRF what we are going to use. So this space was filled with PRF and bone graft, and the leftover PRF was used as a membrane, and then we sutured it back. So we achieved great results in this, and after 6 months, when we opened the site, we were able to place the implant into this zone. Now, another study going on. We've already finished in the department. Evaluation of peri-implant soft tissue and bone level in dental implants placed in healed bony sites with or without platelet fibrin and PRF liquid. So in this study going in, which is already done in a department, the student who has done this study under me is it's under publication in a very reputed journal, and obviously we got a lot of laurels for this study. And in this, we used PRF as well as PRF liquid. I'm going to show you some pictures related to the study. Dental implants placed with PRF. I'm not going to show you the sites which were without PRF, just the sites which were used with PRF. So this is the extraction site. You can see clinically, this is an extraction site. We want to place a molar. So this is the radiograph showing the space where we want to place the implant. We have adequate width and height. So in this case, what we do is we also preserve the PRF liquid. Now, our aim in this study was we dip the implant in PRF liquid for about 60 to 90 seconds. So the whole implant surface is coated with the PRF liquid. So this whole implant, when coated, it absorbs it. The implant the titanium looks like red after dipping into the solution of PRF, and then we successfully placed the implant, which was dipped in PRF liquid. Then we took the PRF, we took the PRF membrane. We have the apparatus to make the PRF membrane by compressing it. This PRF gel was converted into a PRF membrane, placed on top of the defect in which not the defect, the place we are treated. We have covered it like a membrane, sutured it, and you can see this is the implant placement. This is when we exposed after 3 months. This was the condition of bone fill, and this is the photograph after the prosthesis. So you can see there is no bone loss, and we have achieved very good results in terms of PRF. Now you must be wondering why liquid and why the membrane. The liquid was used for better osseointegration, and the membrane was used for a better soft tissue. The papilla fill index in this study, again, we had great papilla fill in at 6 months. You can see we achieved great in terms of graph. Because of the PRF, we had great papilla fill index. Crestal bone loss was minimal, probing depth minimal. Yeah. So this was the role of PRF in periodontics. Now, yes, there is role of PRF in endodontics as well. So the use of antibiotic paste for canal disinfection along with PRF strengthens the effectiveness of sterilization in carious teeth, infected dentin, periapical lesions, and necrotic pulp. The potential behind success of PRF as a super drug in regenerative endodontics was stressed by Huang et al., who concluded that PRF does cause proliferation of human pulp cells. It also increases the expression of osteoprotein and alkaline phosphatase. So you can imagine PRF also has a role in endodontics because of its various growth factors. It is able to also proliferate cells of the human pulp. So a great role in endodontics. Pediatric dentistry, again, PRP and PRF, they were both found to be much superior to routinely used calcium hydroxide in pulp capping procedures based on the tissue reaction between these materials. So nowadays we can use PRP and PRF in pulp capping rather than calcium hydroxide. Lot of growth factors, amazing results, and no tissue irritation and no immunogenic reaction. In children, we will prefer PRF than PRP because of the absence of any additives which can be immunogenic. Limitations. PRF also has some limitations. Only a limited volume of PRF can be used because it is obtained from an autologous blood sample. The quantities produced are low. This fact limits the systemic utilization of PRF for any journal surgery. So that's why in dentistry, we don't need much of blood. It is getting a lot of, in dentistry, as well as I told you, in hair therapy and also in facial rejuvenation therapies. We don't need so much of PRF quantities. So that's why it's not much used in journal surgery. PRF tissue banks are unfeasible. The fibrin matrix contains all the circulating immune cells and all the highly antigenic plasmatic molecules. That is why PRF membranes are totally specific to the donor and cannot constitute an allogenic graft tissue. So the idea behind PRF tissue banks is not feasible at all. We have to be using on the chair side, prepare it, and we use like mostly within 45 minutes of the PRF gel preparation, we try to use it in the patient's body. Coming to the next derivative of blood, CGF, concentrated growth factors. CGF, like PRF, does not require the addition of any bovine thrombin or any anticoagulants. Furthermore, altered protocols in obtaining the blood sample and the centrifuging procedure, they are very comparable with the PRF. Unlike PRF, however, CGF is prepared with 20 to 60 cc of patient's venous blood, centrifuged at 2400 to 2700 RPM using a specific centrifuge with a rotor turning back and alternated and controlled speed for 12 minutes, resulting in fibrin-rich blocks that are much larger, much more denser, and much more richer in growth factors than the common PRF. Various modes of CGF preparation: acceleration for 30 seconds first, followed by 2700 RPM for 2 minutes, then 2400 RPM for 4 minutes, then 2700 RPM for 4 minutes, then 300 RPM for 3 minutes, and then a deceleration for 36 seconds to a stop. These are the modes of CGF preparation. It requires a specific centrifuge. Not any centrifuge will produce CGF. It is a special centrifuge made by Medifuge Silferdent, Italy. It is specially for CGF. The resulting fibrin block is of a higher quality due to higher concentration of fibrinogen, factor 13, and thrombin, which is obtained. Factor 13A, which is activated by thrombin, cross-links the fibrin clot to increase the stability, strength, and protection against plasmin-mediated degradation. Clot with high tensile strength adhesive strength, and decrease in hemostatic time. So we have a very high tensile and adhesive strength in the clot obtained with CGF, which gives us very good results and very high stability, and also space maintenance under the flaps. Essentially, the CGF is an upgraded version of PRF with a more strengthened fibrin matrix and boosted growth factors and cytokines. It is PRF with an upgraded version. Periodontal ligament cells cultured with CGF membrane showed a marked increase in osteogenic markers needed for healing, such as collagen 1. Then we have bone sialoproteins and osteocalcines. These are the bone morphogenetic proteins which are needed for bone growth. CGF, a superior phase represented by the serum. You can see in this figure, we have serum, a buffy coat, growth factors plus stem cells, and platelet-rich coagulation. So this is how in the test tube you get various formulations of CGF, and interim phase, which is represented by large, dense, polymerized fibrin block. That is this one. A liquid phase containing the growth factors and stem cells, waiting for stimulation and differentiate into various cell types. And then we have a lower red portion comprising of a viscous, dense, platelet-rich coagulation. So if we compare platelet-rich fibrin to CGF, we get a better version of PRF. But again, the instrumentation for this is highly specific, whereas PRF, many centrifuges commonly available can be used for PRF, but not for CGF. CGF membranes are used to cover wounds or reconstructed areas which can stick together thanks to the adhesive power and thanks to their elasticity. They can be sutured. Imagine we were earlier using non-resorbable membranes, collagen. Now we can use patient's own blood, convert it into CGF or PRF, make it into a membrane, and also that can be sutured. At the end of the surgery, any liquid which is left can be brushed with the serum. The affected site can be brushed with the serum. You can see in the figures how these are the cloths we obtain. We make the membranes using the machinery, and this is the beautiful membrane which can be sutured. After suturing, just brush on the serum so that it promotes a beautiful healing. Showing you a case of CGF. In this case of sinus lift and placement of implant, we need some bone volume here. So we use CGF, expose the bone, lifted the flap, open the lateral window for the sinus opening, place the implants, place CGF as a membrane on top of the, after the sinus lift, we did the closure of the space with this membrane. And you can see in the picture the comparison. This is the picture showing the bone growth, the sinus lift, and the associated. This is at 3 months, and this is at 9 months. Complete resolution of inflammation. What a beautiful bone fill and a great sinus lift, showing absolutely great results of CGF in case of dental implant placements using open sinus approach or the lateral window approach. CGF case 2. I just told you and mentioned you, we can use CGF for as a membrane. This is a case of root coverage. You can see around 3 mm root coverage is to be required. In this case, that's the first step. We lift the flap. We are going to do a coronally advanced flap along with CGF. We applied a root biomodification agent, that is 24% EDTA, onto the root surface, so that we get a beautiful fibrin, not fibrin, so that we get beautiful fibers from the dentin. After the smear layer is removed, the collagen fibers are exposed. Now we did suture the CGF membrane. You can see the CGF membrane is sutured with resorbable sutures. Here we have sutured the flap on top of it. This is the result we have got. We have got almost 90% root coverage, stability. You can see the volume also on the top of the gingiva. You can see some increase in the volume as well. So this is how we use CGF and root coverage. No bone added sinus augmentation has many advantages, such as infection is not reported, Significant higher new bone formation is achieved. Patient morbidity is very low because the harvesting of autogenous bone is not required. Risk of cross-contamination from bovine and a human bone is eliminated. Surgical costs can be reduced. I am very much in favor of doing sinus lifts without bone grafts nowadays because of the osteogenic potentials of various forms of PRF and CGF. We get the same amount of bone formation than using a bone grafts along with them or bone grafts alone. I'm trying to use many, not only me, many clinicians are getting very good results using only platelet concentrates and sinus augmentation. Coming to the next material, derived from the blood, mineralized MPM, mineralized plasmatic matrix, also sticky bone, which is a trademark of Dr. Son. A way to prepare the particles of bone grafting or bone substitute that makes it malleable, stable, and enhances the penetration of growth factors inside the graft. Prepared by 12 to 15 minutes at 2500 RPM. This is the technique. Again, after the centrifugation, we get this liquid. We have this prepared. With the syringe, we extract the liquid and we add it to a bone graft, and this acts as an adhesive to this bone graft. And what we obtain is something known as a sticky bone. Since this is adhesive with the bone graft, we get a very sticky bone, adhesive bone called a sticky bone. MPM case 1, a case of implant exposure. Case of periimplantitis, when the flap was lifted, we saw free threads exposed. So we placed MPM, mixed MPM onto the site. You can see we have placed and then we sutured. Later on, when we exposed the site after a few months, a beautiful soft tissue curvature is achieved and there was a great bone fill achieved. See, this case can be treated with PRP as well. This case can be treated with PRF also, CGF, sticky bone. So it's your choice, it's the clinician's choice. What do you prefer for doing any case? I try to make various concentrates of platelets and try to use, and I think many of us are using it. Sticky bone case, it's the case by Dr. Son et al. It shows you can see there is less amount of bone available for the implant placement. We don't have much height, so again with the liquid and the bone we have made something known as sticky bone. So sticky bone, you can see you can pick up the bone in one go like this. The particles are getting holding to each other. That's why it's called sticky bone. The implants were placed, but the threads are exposed. Now what to do? So create some bleeding points onto the bone so that we get some blood for the sticky bone, what we are going to place on top of it. So we created some cortical, what do you say, with the burr, we did some cortical holes and we placed osteogenic sticky bone on top of it, covered by a membrane to stabilize it. Since it is a mandible and also we need to stabilize, we need volumes of bone. We covered it with a membrane, and this is the exposure after 6 months. You can see the sticky bone where we had placed, it has not transferred anywhere, and you can see an awesome bony architecture in Dr. Son's case, in which he used sticky bone to promote volumes for these threads were earlier exposed, and these threads are all covered in case of this, and the patient was given a very beautiful prosthesis after that. MPM is a natural evolution of PRP and the PRF. It enhances transport of the material by securing its implementation. The interesting part in the MPM is the mineral fraction, which is either autologous bone or any other bone graft or bone substitute. This mineral part is not present in old PRF or PRP. This offers MPM the stability and the resistance to the chewing forces. So we discussed almost all the derivatives of blood which are being used routinely in dentistry. We discussed how it is used in perio. We discussed how PRP, PRF, CGF, MPM, various forms of PRF, how they are used in dentistry, in periodontics, in endodontics, in pediatrics, in oral maxillofacial surgery. So it is a jungle of platelet products out here. And again, I'll say no preference for any. It's the clinician choice. So we have the patient's blood. Make whatever you want and use it, and you will get very good results. Best of luck if you're using any of these techniques. And with this, I would like to conclude my lecture, and I hope that I gave a presentation that will help you to to the general practitioners mainly to add these therapies to your clinic for best results. Thank you so much for being a great audience. Dr. Canor, I'm done.
All right. Thank you for that, Dr. Singh. What an amazing presentation and the comments that are coming in. So, we'll wait for a few seconds to see if we can get the doctor back. All right, maybe we'll do the Q&A session on the site here. I wanted to thank Dr. Singh for all of his dedication to this project. And we will ask him to join us again on the site comments in the below to address any questions that you may have. We apparently have a technical glitch here. Thank you so much, and we look forward to seeing you in the next session in a few minutes to come. Thank you.